So our next speaker is Dr. Elaine Cheng. Dr. Cheng trained on the East Coast. I think I'm right about that. I might have got you muddled up. You were at Cornell, right? And then came about 4 years ago to the West Coast and has been doing a training in abdominal transplant surgery, and now takes a good deal of responsibility for short bowel patients who are on home therapies, both adults and children. So she's a very valuable person on their faculty. All right, you have 20 minutes.
Okay. Thank you, Dr. Howard. So I'm actually going to give you more of an overview of the general management of patients with intestinal failure. So starting out, how do we define intestinal failure? And we define it as the reduction of intestinal function such that the intestine is not able to absorb enough nutrients or water or electrolytes, and such that intravenous supplementation is required. Now, oftentimes we're referred to patients with short bowel syndrome, but I want to stress that short bowel syndrome really is not synonymous with intestinal failure. And that's because intestinal failure is a much broader term. It does include disorders such as mucosal causes, in addition to short bowel syndrome, as well as functional causes. So, for example, mucosal causes are oftentimes what children can be born with, such as microvillus inclusion disease, tufting enteropathy, congenital neuroendocrinopathy. And we also see a lot of adults and children with functional causes, such as impaired motility, as in chronic intestinal pseudoobstruction, people who have fistulas, adhesions, or blockages from mechanical obstruction. But the vast majority of the patients that we do see at UCLA do have short bowel syndrome. And in adults, that oftentimes is the result of extensive surgical resection. It can be because of trauma, such as a gunshot wound or a stab wound to the abdomen injuring the intestine, or the blood vessels going in and out of the intestine. It can be because of radiation treatments for cancer. It can be because of blood clots in the blood vessels that go in and out of the intestines. Or people with Crohn's disease, which is a type of inflammatory bowel disease, and they tend to get repeated surgeries and repeated resections over the course of their lifetime, and they can get intestinal failure from that. In children, the etiologies are somewhat different, but the end result is the same. For example, gastroschisis, which are children born with an open abdominal wall, necrotizing enterocolitis, which tends to happen in premature infants, and other disorders such as atresia and volvulus. Fortunately, the body has a natural compensatory response to extensive surgical bowel resection. And we call that response intestinal adaptation. And that is the journey from intestinal failure to achieving enteroautonomy. And this interesting process of intestinal adaptation actually involves structural and functional changes in the intestine itself. So the intestine is able to dilate. It moves more slowly, and it also has the villi, which are finger-like projections inside of the mucosa of the intestine, actually grow taller so that there's more absorptive area for nutrients. But on a cellular level, there's also more transporters so that nutrients are able to be transported into the body from the intestine. And we mentioned the transit time, which the end result of which is increased nutrient and fluid absorption. So how do we help along this process of intestinal adaptation? And that really requires a multidisciplinary approach. So sometimes the anatomic features are predictors of whether somebody can achieve enteroautonomy. And these features we may not be able to alter, but there are things that we can change. And speaking of a multidisciplinary approach, that requires adequate nutritional support, and that initially starts for everybody with TPN, parenteral nutrition, but we also emphasize the early introduction of an enteral feeding program. Medical therapies, and that includes some growth hormones and other factors that we're going to discuss. as well as surgical therapy. And these can include such as bowel lengthening procedures, ostomy takedowns, which and the technical term we have for that is the autologous reconstructive surgery, or it can involve transplantation. So the proper management of somebody with intestinal failure really requires a comprehensive program. So let's start by saying a couple words on anatomic features. So at UCLA, we actually have a home TPN program that was established back in 1975. And back in 2000, we have published our experience that included 78 children who required TPN for over 3 months, and these children had short bowel syndrome. So what we found in this analysis was that the favorable predictors of survival and intestinal adaptation included longer small bowel length, and the cutoff that they found in this particular study was 38 centimeters. The presence of the ileocecal valve, which is the valve that is present right at the junction between the small bowel and the colon. Preservation of the colon is also a favorable predictor, as well as intestinal continuity. And what we mean by that is using every segment of the intestine that you have and taking down any ostomies that somebody may have. Also, a couple words about nutritional support. You've heard about that from Dr. Calkins earlier this morning. And TPN is required for everyone initially that has short bowel syndrome and intestinal failure. But we do emphasize trying to wean TPN, and we do emphasize trying to introduce enteral nutrition at an early stage. And that's because TPN does come with complications. What are some of the possible complications with TPN? As you know, TPN requires a central venous catheter. This catheter can get infected and cause a severe infection. The catheter itself can malfunction or be blocked. The catheter can also cause thrombosis of the vessels or blood clotting in the vessels that they're sitting in. And we only have so many of those vessels available. Liver disease, which we have already heard about, gallstones and gallbladder disease, kidney stones, as well as deterioration in kidney function, bone disease, and in severe cases, these complications can be life-threatening. So how do we prevent and minimize TPN complications? So as I mentioned before, emphasizing weaning and introducing enteral feeding. Proper care of the catheter and preventing catheter infections, and you're going to hear a lot more about that from Lori Rayan after me. And preventing vascular thrombosis. Particularly a lot of the adult patients that we treat, we will find procoagulation or prothrombotic disorders that they were born with. So it's important to identify these disorders, these genetic disorders, and place people on anticoagulation if that's necessary. And then optimizing the TPN formulation, and you've heard a lot about different lipid formulations, such as fish oil emulsions. This is actually data from Kara Calkins, and this is our trial of 24 weeks of Omegavan in children with parenteral nutrition-associated liver disease. And as you can see, the bilirubin for children receiving interlipid continues to go up over the 6-month period, whereas those children who were receiving Omegavan had dramatic improvements in their bilirubin levels. So let's talk a little bit about medical therapies. So traditionally, people have talked about glutamine and growth hormone. Glutamine is an amino acid, which is a building block for proteins, and it actually is the major food source for cells in the intestine. Growth hormone, along with glutamine, has shown some promising data in rat models and other animal models. However, in clinical trials in humans, they have not demonstrated any reproducible or meaningful benefits. Now, there is a interesting compound and rather promising compound that has come onto the market, and this is glucagon-like peptide 2, or GLP-2. This is actually a natural factor that is produced by the body, and the body increases the production of this factor in response to intestinal resection. And those people who are more likely to adapt actually produces more GLP-2 than people who fail to adapt. So, however, the GLP-2 that is naturally produced by the body has a very short half-life. And so what scientists have come up with is a GLP-2 analog that lasts longer in the body. And that is being marketed as Gattex. And Gattex was actually FDA approved for use in adults back in 2012. It is a daily subcutaneous injection, and some of the clinical trials that have been carried out with Gattex, and these were given in 6-month intervals, and there's also a long-term study that is becoming available at this point, but the patients who received Gattex actually had increased villus height, so more absorptive area in their intestine, and they also had decreased needs for TPN as well as intravenous fluids. So that is a medical therapy that can be considered for certain populations. Now, moving on to surgical therapies. So surgical therapies are broadly divided into non-transplant therapies as well as transplantation. So starting with non-transplant therapies or autologous reconstructive surgery, for people with fistulas, the fistula should be taken down and managed. For those with blockages due to strictures, which are areas of narrowing or intestinal adhesions, those should be dealt with as well. We mentioned that if you have an unused segment of intestine, that should be used. And so that speaks to taking down ostomies and restoring intestinal continuity. Not too long ago, we had a patient who had a gastric bypass and subsequently lost her intestine. And we actually reversed her gastric bypass so that we can use the unused portions of the stomach as well as the unused portions of the intestines to try to preserve intestinal length. And finally, there are lengthening procedures that can be offered. And these are typically the Bianchi and the step procedures. So what are these? So the Bianchi procedure is also called the longitudinal lengthening procedure. And what it is that it takes one short dilated segment of intestine, and we actually divide it into two narrower tubes. And then we join these tubes, two tubes end to end so that you're creating a longer segment of intestine that is narrower. And that is occasionally offered to children who have short gut syndrome. Now, the more commonly used at UCLA, the procedure that's more commonly used is the STEP, or the serial transverse enteroplasty procedure. And that's really actually an ingenious procedure that was designed by Hung-Bae Kim up in Boston back in 2003. Now, in surgery, we use these staplers that actually lay down 2 rows of staples on either side and then cut in between. So Dr. Kim figured out that if you cut the bowel in this zigzag manner, you create a V shape, which actually creates a longer, narrower segment of bowel. And so Dr. Kim now has kept an international registry of all of the step procedures that have been done around the world. So this is his 2010 update of this registry. It included 111 patients of step procedures that were performed across the world in over 50 centers. And these are the results. So out of the 111 patients, we don't really have good follow-up data on 17 patients. So that leaves us with 94 patients. Unfortunately, 9 patients died after the procedures. 4 still required transplantation. There were 8 patients who remained 100% dependent on TPN. But 14 patients are partially dependent on TPN and partially dependent on enteronutrition. However, 45 patients out of this group were able to come off of TPN altogether and were able to be maintained on 100% enteronutrition. Now, 14 of these patients actually underwent a second step procedure, and 2 of these even had a third step procedure. And from that group, 3 additional patients were able to achieve enteral autonomy. So all in all, pretty encouraging results. Over 50% of the patients were able to come off of TPN altogether and achieve enteral autonomy. So finally, a couple words about intestinal transplantation. I do want to say that we reserve intestinal transplantation only for people who develop life-threatening complications on TPN. And these complications include liver disease, severe loss of vascular access, meaning many central veins are clotted as a result of repeated catheter insertions, recurrent catheter sepsis, and particularly if somebody gets a yeast infection, that is somebody that we would refer for transplantation more promptly. Somebody who has very complex fluid and electrolyte management, and somebody who, let's say, has no small bowel or very little small bowel left and has no chance at adaptation and a non-reconstructible GI tract. Now, we can mix and match organs in intestinal transplantation. So there are several graft options that we can offer to patients. For somebody who does not have any liver disease, we can do an isolated intestinal transplant. For somebody who does have liver disease, we can do a combined liver intestine. For those who have disorders of the foregut, which means disorders of the stomach and the pancreas as well, we can offer what's called the true multivisceral transplantation. And for someone who does not have liver disease but needs a pancreas and needs a stomach, we also have what's called a modified multivisceral transplantation. So for patients who are referred to us for transplant evaluation, we consider their anatomy and their organ functions very, very carefully and would decide upon one of these graft options. And you notice, if you're observant, you can also notice in this figure that sometimes we also offer a colon, and that's also an optional organ that we can include in the transplant. So about a year ago today, a lot of us traveled to Argentina, and we presented the outcomes from our intestinal transplant program at UCLA. So in this particular update, we had 136 transplants that were performed over 22 years since the inception of the program in 1991. Our overall 5-year survival was 66%, so 2/3 of the patients are still alive after 5 years. However, complications are common. They include rejection, which occurred in almost 60% of the patients. CMV is a virus that can cause infections in transplant patients, and that caused infections in 7% of the patients. And post-transplant malignancies is actually rather common after intestinal transplantation and occurred in about 15% of our patients. So how do we compare to the national and the global outcomes? So if we're looking at US data and global intestinal transplant data, actually short-term survival, meaning 1-year survival, has improved a lot over the past couple of decades. And in isolated reports, even 80 to 90% 1-year survival rates have been reported. Now, if we look at medium-term survival, though, which are survival at 3 to 5 years, that still lags. In the UNOS registry, which keeps track of all of the transplants done in the United States, the survival is only 40 to 50%. And in the global intestinal transplant registry, the 5-year survival is about 50% right now. And finally, for long-term outcomes, which are outcomes at 10 years, those are rarely reported for intestinal transplantation. And as of 2015, the intestinal transplant registry reported a 10-year survival of 43%. So you may ask why? Why do we have such poor survival rates after intestinal transplantation? Now, first of all, it's a younger field. We don't know as much about intestinal transplant as we do know for liver or kidney transplants, which have been around for 50, 60 years at this point. Now, the intestine is also what we call a very immunogenic organ. That is, it is very prone to rejection. It is a very immunologically active organ. And so we have to give these patients a lot of anti-rejection medications in order to prevent rejection. And yet rejection is still one of the most common causes of graft loss after intestinal transplantation. Now, however, long-term use of these immunosuppressive medications can have side effects, and some of these include diabetes, hypertension, they can cause impaired renal function, and they can also cause post-transplant malignancies as well as severe infections. And in fact, severe infections is the #1 reason why we lose patients after intestinal transplant. And a lot of these complications are more common in intestinal transplantation than in, say, kidney transplantation or heart transplantation or liver transplantation, because we have to use such high doses of these immunosuppressive medications. So in summary, it really requires a coordinated effort on the part of not only the family, the patient, but also on the part of dietitians, nurses, nutritionists, TPN specialists, medical physicians, as well as surgeons in the management of patients with intestinal failure. And we can really optimize nutritional support with the use of medical therapies and surgical options to help along this process of intestinal adaptation and helping you along in the achievement of enteral autonomy. So in summary, for nutritional support, initially TPN is required for everyone, but we do emphasize early weaning of TPN and early introduction of enteral nutrition. And we do have strategies for minimizing TPN-associated complications, and which includes the use of, let's say, fish oil-based lipid formulations. Medical therapies, the GLP-2 analog or GATTEX can be considered in selected cases. And surgical options should really be considered for all. Ostomy takedown or restoring intestinal continuity is important. The STEP procedure is a bowel lengthening procedure that can be considered and offered, and the best candidates for the STEP procedure are actually patients who have dilated bowel segments and are only partially dependent on TPN to start out with, and they don't have any advanced liver disease. And intestinal transplantation, I often counsel my patients that it is really swapping out one set of problems and then getting another whole set of problems in return. And so we reserve intestinal transplantation for people who fail intestinal adaptation or develop life-threatening complications. And with that, I welcome any questions or comments that you may have. Thank you for your attention.
Well, that was another immaculate talk. Fantastic. Yeah. So, question over here.
Yeah, two questions. One is on your last chart. One of these charts was confusing. You talked about TPN, and then it sounded like you said you wanted to go to enteral feeding. Did you really mean that, or that was just another therapy? Are you recommending that people on TPN eventually go to enteral feeding?
So that's a great question. So we actually individualize treatment plans for everyone. So TPN is necessary in the initial stages of after bowel resection or in the initial stages of intestinal failure. And in some selected cases, long-term TPN therapy is appropriate. However, if there is a chance of intestinal adaptation, we do emphasize weaning TPN, and we do emphasize trying to introduce enteral nutrition. And enteral nutrients in the gut itself can be a stimulant for additional intestinal growth and adaptation.
So just follow on to that, and then I have one other. So who would make that decision? That's a big decision. I've been on TPN. I've got a second question. I've been on TPN about 8 years.
Mm-hmm.
I'm 71 years old. So is somebody saying that I ought to think about going to enteral? Because that's the first time I've ever heard that.
No, and like I said, the treatments are very individualized. For some people, like yourself, TPN, long-term TPN may be appropriate. Now, in terms of who makes that decision, it's really a coordinated team effort. It's an effort between the patient, the family, as well as all of the care providers. If there is a chance at intestinal adaptation, we will often offer that chance. We'll often give them a try. However, this is oftentimes a multidisciplinary and a coordinated decision.
Okay, then I'm sorry. So then the other question I have is, I'm not asking for a diagnosis, but I have short gut. I've got 100. Had a small bowel bypass, but I had 100 centimeters supposedly of good gut there, but I also have radiation enteritis. As a result of my small bowel thing, I wound up for 2006 through 2010 on TPN.
Mm-hmm.
I was able to wean myself. Don't ask me how. And then a year and a half ago, this was 2010, and then a year and a half ago, started losing weight, and I'm back down on TPN for a year and a quarter. So the general question is, I'm not asking obviously for a diagnosis, but what can we learn from that, and does that somehow will help people? Because I was very happy obviously to get off of it, and then and I have no idea why it happened, and then I got back on. So is there any studies or recommendations with respect to that?
I think we could actually touch on a lot of topics based on your experience, and everybody's experience is different. However, what you had gone through, having been able to come off of TPN and having and needing to go back on is not uncommon at all. And there are certain conditions that something may have happened in the meantime which may have necessitated you going back on TPN. But this is something that you can discuss further with your doctor, and we'll be happy to discuss later in the afternoon as well with you. Yes. Sure. Sure.
I was wondering if you could.
Let's just have an agreement. If you want to ask a question, put your hand up, and somebody will arrive with a microphone.
I'm sorry.
Okay.
No problem.
Don't. She pointed at me. I'm sorry. I'm wondering if you can say a little bit about the experience of step procedure for folks with Hirschsprung's.
We actually have not done a step procedure on folks with Hirschsprung's, so I cannot really comment on that.
I'm on a European committee for home artificial nutrition
Louder.
and chronic intestinal failure. And our chairman is Loris Peroni, who you probably know. Some
Sure.
years ago, Loris, I think the last time it was published was maybe about 5 years ago. He followed patients who were approved for transplant, but for whatever reason were not transplanted, and compared them to the ones who were transplanted. And in fact, survival was better in those who actually did not get the transplant. Are you aware if he's updated that at all? I haven't seen a follow-up to that.
I haven't seen a follow-up or the latest data from him either, although I'm not surprised to hear that he had reported that before, that the survival after transplantation was even worse than what was the survival on TPN.
But again, it was 5 years ago.
Right, and outcomes have improved, exactly. However, as I mentioned in my talk, the 1-year survival has really improved dramatically as of 20 years ago, but the long-term survival really hasn't improved all that much.
Hi, were there any similarities of the patients who passed after having the step procedure?
That is another great question. However, I do not have the exact or the granular data from the STEP registry, and I don't want to conjecture what similarities they may have. But that is an interesting question. And so.
I have a question over here. It's kind of twofold. I've seen recently in talks that the medical community is becoming a little bit more conservative in their approach to the STEP procedure due to the complex innervation of the GI tract and its impact on peristalsis once it's been done by cutting the longitudinal and cyclical nerves. Have you seen a trend towards that in the community here? What are your thoughts on that? That's the first part of the question.
Okay. So in response to your first part of the question, is I would say that we've always taken a very cautious approach to offering STEP. And oftentimes peristalsis is impaired just because of when the patients are referred to us, they already have dilated segments of bowel, which oftentimes has impaired motility because the intestine has adapted to try to absorb more nutrients. And so we haven't really run into any problems in terms of innervation or after the STEP procedure.
Mm-hmm.
However, we've always taken the approach that we really carefully select our patients for the STEP procedure.
All right. And then the second, I was looking at the data of people who've come off TPN after having had the STEP procedure, and I'm curious to learn what other variables were there for the people who did versus did not come off. What was the amount of bowel that was remaining prior to the procedure? What was abduction looking like prior to that? Was there an ileocecal valve present? Were there other factors that may have contributed to that those people who may not have had the STEP procedure could have potentially come off TPN regardless of whether or not they had the surgery?
Right. very similar to the previous question that was raised here, I do not have the exact granular data from the STEP registry for right now. However, the only factor that we were able to identify was that patients who were already just partially dependent on TPN were more likely to completely come off of TPN after the STEP procedure. So if they were dependent on TPN for 25 to 75% of their calories, then they were more likely to come off.
Hi, thank you so much for that presentation. Our daughter is currently being assessed for transplantation by UCLA and actually has an appointment with your panel tomorrow morning for her second eval. But just to go along with the candidacy for needing transplantation, do you consider loss of motility like pseudo obstruction, dysmotility as a part of being ready for transplant, given that she also has short bowel syndrome?
Great. I'll see you tomorrow morning. I'm sure we can talk more about it. Sometimes patients do get referred to us for transplantation due to pseudo-obstruction and impaired motility. And I think it goes into our global decision in addition to this short bowel function. However, for patients with intestinal pseudo-obstruction, we oftentimes try to entertain other medical or surgical options prior to considering transplantation. But when I review your daughter's records, I'll be able to give you a even more detailed response.
Yes, I was wondering if you have any experience in transplantation in patients with either mitochondrial disease or mitochondrial dysfunction.
Right. Great. So for intestinal transplantation, I cannot remember too many referrals for mitochondrial dysfunction. However, we did have one that was that we saw recently. We also see a lot of we also run a liver transplant program, and we see a lot of children with mitochondrial disorders. In our general experience is that we see that mitochondrial disorders can have neurologic manifestations as these children progress in life, and that is a systemic disease that we cannot fix with transplantation. So oftentimes, due to quality of life considerations, having a mitochondrial disease really gives us pause as to whether we should transplant someone.
Can I just take the privilege of asking you a question? I think both with long-term parental nutrition and certainly post any of your procedures, the issue becomes how can we refer that individual or that child back into the community and get adequate follow-up, and it's not getting easier. So you're obviously managing a big sector on the West Coast, and you've been on the East Coast. So what is your thoughts about down the road how these people are going to be supervised?
Well, I think that's great because we oftentimes want, particularly for our adult program, and we want to refer some of our patients to the local gastroenterologist, and that there really is a lack of specialists who are comfortable in managing intestinal failure and TPN, not only in California, but even in the surrounding states. So I would really want to emphasize education of the gastroenterologist, try to recruit interest, and we would be happy in helping, in fostering this sort of educational program and helping gastroenterologists along in the local community. But this is a real need.
I have one quick announcement, and I just can't resist.
Mm-hmm.
The Oley Foundation meeting in 2017 is being planned on the heels of your meeting in New York City.
Oh.
And Kishore Iyer, who I think many of you are familiar with, has promised us the highlights from your meeting at our meeting. So there's a good reason. The dates are July 5th to the 9th. At the Hyatt Regency in Old Greenwich, Connecticut, close proximity to New York City.
Great.
Terrific.
Great.
Well, thank you very much. That was
Thank
fabulous.
you.